Let's move on to pancreatic cancer. So pancreatic cancer, like most of our GI tract cancers, is an adenocarcinoma, and it arises from those pancreatic ducts that we talked about earlier. It's usually located at the head of the pancreas. And so from our anatomy section here, we talked about this being the head of the pancreas. And the relevance to this is that you have your main pancreatic duct that kind of goes like this, and you also have your common bile duct that ends up attaching to it in this pattern. And so if you have a cancer blocking this region, you're not only going to have pancreatic duct problems, but you'll have your common bile duct getting obstructed too, which may cause jaundice. So risk factors for pancreatic cancer, it's often in older adults. A big risk factor is smoking. It's very common to see that on a question stem. You can also get pancreatic cancer with diabetes. Certain races are at higher risk, including African American and Jewish ancestry. A big risk factor they do test on occasionally is chronic pancreatitis. So if you have chronic pancreatitis, you are at increased risk of pancreatic cancer. I just want to point out, though, that alcohol is not directly associated with pancreatic cancer. Obviously, alcohol use can cause multiple bouts of acute pancreatitis, which can lead to chronic pancreatitis. And in that setting, then the chronic pancreatitis would be a risk factor, but independently, alcohol use is not associated. Some genetic associations you should be aware of, and they do test these, is the KRAS and SMAD4 mutations. I've seen this several times on a test where they'll give you a classic pancreatic cancer and they'll ask you what's a risk factor for it. And they'll include alcohol use, and then they'll give you like an SMAD4 mutation. And you'd have to remember that alcohol is not a risk factor, but this one is. You can also see BRCA2 mutations causing certain hereditary pancreatic cancers, especially of Ashkenazi Jewish descent. So let's talk about the presentation of pancreatic cancer now. The classic demographic, it shouldn't surprise you given the risk factors. They love to test you as an older individual with a significant smoking history. 9 times out of 10, this will be the demographic given if they're trying to point you in the direction toward pancreatic cancer. Another thing I want you to realize, and sometimes this is tested, is if you have an elderly individual who has new diabetes, especially if they don't really have risk factors for type 2 diabetes, they're usually kind of almost cachectic, they're almost in the other direction. And if they develop diabetes and weight loss and a few other symptoms, you should be considering pancreatic cancer. And so secondary diabetes, what's going to happen is if we have our ACE in our cells and our ducts, we also have islets of Langerhans that exist all throughout our pancreas. And if you have a huge pancreatic cancer starting to grow, you can start to diminish the functionality of these islets of Langerhans, and you can develop secondary diabetes. So this will present like most cancers do with weight loss and anorexia. You'll have epigastric abdominal pain, and you can get this obstructive pattern, obstructive painless jaundice, pale stools, and dark urine. And we'll go over each of these 3 now. What I wanted to mention here is that, and we'll talk a lot about this in the hepatobiliary section, is that bile is formed from a few different components. And what's going to happen in this case, especially in the case of jaundice, is that bilirubin getting stuck inside of our bloodstream instead of being excreted into the duodenum is going to cause a lot of different symptoms, including these 3 up here. So again, I'll go over this in the hepatobiliary section, and this is a good time to go over it, I think, because when I was studying for step 1, I feel like sometimes all these symptoms seemed like they were disjointed, but these, you're going to see all of these symptoms, including many more, in any pattern that obstructs your common bile ducts. So these are going to be very common, this clinical presentation. So pancreatic cancer can cause these for a few different ways. We'll start by talking about why pancreatic cancer can cause jaundice. If you have a pancreatic mass blocking this outflow tract, then this bile cannot escape to the duodenum. And instead, that bile is going to leak out into your bloodstream. And anytime you have conjugated bilirubin, or unconjugated actually, anytime you have bilirubin in your bloodstream, that can lead to jaundice or yellowing of the skin. Pale stools arise for a similar mechanism. What's going to happen here is that we need the bile to reach our GI tract in order to provide that brown pigment in our stool. So if we have this pancreatic tumor blocking this whole pathway, what's going to happen is that the stool cannot turn brown and it'll stay pale. For dark urine, what's going to happen here is that under normal circumstances, our red blood cells break down into bilirubin in our blood. And this bilirubin is unconjugated. So if this bilirubin tries to escape, it's going to get stuck in the kidney and secreted back out into the bloodstream. And I remember unconjugated bilirubin as being water unsoluble to remind me that it cannot be excreted with the kidneys because the kidneys need water soluble compounds to be excreted. What's going to happen? So how do we fix this? How do we get this bilirubin out? Is our liver is going to take over and it'll convert that unconjugated bilirubin into conjugated bilirubin. And from there, that conjugated bilirubin, as we saw before, that can be excreted along inside that bile. That's a component of bile. But what's going to happen in pancreatic cancer or other obstructions is you're going to have a big blockage, and that conjugated bilirubin now will get secreted back into your bloodstream. And this conjugated bilirubin is water soluble. So it can actually get excreted in your urine and you'll end up with dark urine because of conjugated bilirubin. You'll also get steatorrhea, which shouldn't surprise anybody. You're going to have fat malabsorption for some of the same reasons we've already talked about before. I can show you some right here. So steatorrhea are fat, greasy stools, and they're often caused by excessive fat. So if we have our pancreatic enzymes here, they usually get secreted into your duodenum, and fat can get broken down into smaller micelles. But if you have a big obstructing mass, or you have a mass that's destroying a lot of your acinar cells in the first place, then you won't have as much pancreatic enzymes in your lumen, and you'll have these large fat globules that cannot be absorbed, and instead they end up being excreted as feces. On physical examination, there's a few things they like to test. There's something called the Courvoisier sign, which is a non-tender palpable gallbladder. So why does this happen? So what's happening here is that we've seen this process many times now, that bile likes to flow out this outflow tract. If we have this blocked, what's going to happen is that, sure, some of that bile does escape into the bloodstream, like we've seen many times so far, but some percentage of that bile ends up getting stuck in the gallbladder or pushed back into that gallbladder. So over time, you're going to actually have a growing gallbladder because you have so much bile stuck in there. And I remember this as Courvoisier sign is the gallbladder becomes curvier in Courvoisier because it's a non-tender palpable gallbladder. Another syndrome you should realize that's associated with pancreatic cancer is Trousseau Syndrome, also known as migratory superficial thrombophlebitis. This is caused by multiple blood clots usually in your extremities due to a hypercoagulable state. Most cancers do cause hypercoagulability, and here you can see Trousseau sign is all these mini blood clots here. And for this one, I remember Trousseau as thrombophlebitis. A few more tidbits about pancreatic cancer before we move on. Just know that if you're testing laboratory studies, CA19-9 is the most useful to monitor the response to treatment. You can also use CEA in some capacity, and some oncologists use that, but if you're on a test and they give you both of these laboratory markers, CA19-9 will be correct. For imaging, you can use a CT scan or an MRI to diagnose the cancer. And the treatment is a Whipple procedure. And a Whipple procedure is a very extensive procedure where they take out the gallbladder, part of the stomach, your duodenum, the head of your pancreas, and they have to attach this to the distal portion of your intestine. It's a mess. I had to actually rotate it. During my surgery rotation, I was part of a Whipple, and it took like 10 plus hours, and I'm not a big surgical guy. But interesting nonetheless. And that's how you would need to treat it. You'd need to treat it with the Whipple, and then you'd still need chemoradiation and all that jazz. And I think that's what's next. Yeah, so treatment is Whipple and chemoradiation. And even if you have all of this standard of care going for you, pancreatic cancers are still very, very dangerous, even early stage pancreatic cancers. So the prognosis is very poor, and the average survival is about 1 year after diagnosis. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.